Welcome back to My Hematology. This is where we take complex concepts of hematology and break it down to simple bite sizes for easy understanding. Okay, so today we're building an overview around macrocytic anemia. When you're handed a complete blood count and you see those enlarged red blood cells, it can feel like this daunting puzzle, right? But don't worry. By the end of our time together, you're going to have a systematic framework to track down the exact cause. So here's what we'll be covering today. First, defining macrocytosis. Second, causes of megaloblastic anemia. Then we move on to non-megaloblastic causes. Fourth, drugs and hidden mimickers which can contribute to macrocytic anemia. And finally, the diagnostic approach. Let's get to it. Let's define what is macrocytosis. This number right here, this is your starting line, an MCV strictly greater than 100 femtoliters. As you know, the MCV tells us the average size of the red blood cells. Under 80, we're in microcytic anemia, like with iron deficiency or thalassemia. Between 80 and 100 is the normocytic baseline. But the literal second that MCV crosses over 100 femtoliters, those cells are officially larger than normal. Macrocytosis is really just a lab finding. It literally just means the cells are big. That's it. Megaloblastic anemia, on the other hand, describes a very specific bone marrow pathology where DNA synthesis is failing. So the main takeaway here is that all megaloblastic anemias are macrocytic, but not all macrocytosis is megaloblastic. All right, moving on to section 2, megaloblastic anemia, the DNA defect. The two undisputed heavyweights in this category are vitamin B12 and folate deficiencies. Both of these essential nutrients are absolutely required to synthesize DNA. So what happens when they're missing? Well, the cell's cytoplasm just keeps on growing, but the nucleus totally lags behind because it can't divide. It's a classic finding known as nuclear cytoplasmic asynchrony. For B12 deficiency, the symptom we have to keep an eye out for, apart from the usual symptoms of anemia, is the beefy red tongue. That's atrophic glossitis. Also, patients with one autoimmune disease, like Hashimoto's thyroiditis, are highly prone to pernicious anemia. That's where autoantibodies destroy the intrinsic factor needed to actually absorb B12. Now, for folate deficiency, we want to watch out for the elderly, or maybe an isolated patient who's surviving on a very limited tea and toast diet, entirely devoid of fresh leafy greens. You see, our body has this massive, years-long reservoir of vitamin B12 stored up. Folate stores, though, they're tiny. They can literally be completely depleted in just a matter of weeks. And bringing up folate actually highlights one of the most dangerous traps in all of hematology. It is medically dangerous to treat a macrocytic anemia with folate alone without checking B12 levels first. Why? Because giving folic acid will actually fix the blood smear. The macrocytosis totally goes away. But that underlying B12 deficiency, it's allowed to just progress silently, destroying the spinal cord myelin and causing irreversible subacute combined degeneration. So the rule of thumb is always check the B12. This brings us to section 3, non-megaloblastic anemia. So what's physically expanding these cells? The common culprits here are liver disease, severe hypothyroidism, and chronic alcohol abuse. In liver disease, impaired lipid metabolism basically causes excess cholesterol and phospholipids to deposit directly onto the red blood cell membrane, physically expanding its surface area. Then chronic alcohol abuse, which is a real triple threat. It directly poisons the marrow, causes membrane lipid alterations, and it often comes hand in hand with poor nutrition. Finally, hypothyroidism slows down overall erythropoiesis. The exact mechanism of the size increase is not fully understood yet. Megaloblastic macrocytes are typically oval-shaped, but in liver disease, the excess membrane causes the cells to kind of bunch up in the center, creating these round target cells. So if we see perfectly round macrocytes in the peripheral blood smear, our suspicion should instantly shift to the liver, or maybe alcohol use. Now, for hypothyroidism, the macrocytes are usually normal to mild in size. We use TSH and free T4 tests to confirm what's going on. Let's shift our focus now to drugs and hidden mimickers. If we ever see an MCV strictly greater than 130 femtoliters, alarms should immediately be going off in our head. This extreme threshold is a massive red flag for drug-induced interference. We're specifically talking about chemotherapeutics like hydroxyurea, or maybe older antiretrovirals like AZT. We often use a rising MCV as a clinical marker just to make sure patients with sickle cell disease are actually taking their hydroxyurea. Now, can a patient have a severe B12 deficiency but present with a totally normal MCV? The answer is a resounding yes. Welcome to the normal MCV diagnostic trap. This happens when a patient has mixed anemias, a concurrent iron deficiency, which shrinks the cells, mixed right alongside a B12 deficiency, which enlarges them. The automated average, it falsely reads as completely normal. To catch this sneaky presentation, we've got to look at an elevated red cell distribution width, the RDW, and manually review that peripheral smear. Next up is a highly overlooked masquerader, copper deficiency. A high intake of zinc, which actually frequently comes from excessive use of zinc-containing denture creams, literally traps copper in the intestines and blocks its absorption. And without copper, iron can't be incorporated into hemoglobin. This creates a whole syndrome that perfectly mimics the debilitating neurology of B12 deficiency. While the bone marrow looks exactly like Myelodysplastic Syndromes, or MDS, literally countless patients have been misdiagnosed with bone marrow cancer when all they really needed was a simple copper supplement and a different brand of denture cream. Speaking of MDS, it is absolutely crucial to contrast a failing marrow with a working marrow. MDS is a failing marrow disorder. Genetic mutations are causing ineffective, malformed cells. Look for those pseudo-Pelger-Hewitt cells, which have neutrophils shaped like little dumbbells. But on the complete opposite end of the spectrum, a working marrow that's responding to bleeding or hemolysis is frantically pumping out thousands of massive, immature red blood cells, called reticulocytes. On a smear, these have a bluish tint, which we call polychromasia. This is essentially a false macrocytosis. It just means your marrow is doing exactly what it's supposed to do to replace those lost cells. All right, let's tie it all together. I want you to think of the workup in 3 practical tiers. Tier 1 is the basic screen. We check the CBC and the reticulocyte count. If those reticulocytes are high, well, we're looking for bleeding or hemolysis. But if they're low, we move to Tier 2, nutritional. Here, we're testing for B12 and folate. If those labs come back confusing or borderline, we test the methylmalonic acid, which we'll break down in just a second. Now, if nutrition is completely normal, then we advance to Tier 3, specialized testing. This is the stage where we check the TSH for hypothyroidism, LFTs for liver disease, or even perform an invasive bone marrow biopsy if we really suspect MDS. If the serum B12 is sitting in that frustrating gray zone, we look at the methylmalonic acid, or MMA, and homocysteine, because B12 is specifically required to convert MMA. An elevated MMA alongside an elevated homocysteine absolutely 100% confirms a vitamin B12 deficiency. But if the MMA is totally normal and only homocysteine is elevated, that confirms a folate deficiency. How exactly does a simple vitamin deficiency lead to fatal blood clots? Well, think about it. If B12 or folate is deficient, homocysteine builds up in the blood, and this hyperhomocysteinemia is highly prothrombotic. It damages the vascular endothelium and massively increases the patient's risk for deep vein thrombosis and pulmonary embolisms. So when we're correcting a macrocytic anemia, we aren't just fixing some random lab number on a chart. We might literally be saving a patient from a catastrophic clot. Keep that in mind the next time you're looking at a blood smear. Thanks for joining me on this overview of macrocytic anemia, and I'll see you next time.